Thanks very much. Can you all hear me? Yeah. Great, okay. So I'm going to talk about the link between evidence and policy. It's a huge area. So I'm just going to talk about it from a researcher's perspective. Okay, and then we've swapped the order around because when Tim and I looked at our talks, it was pretty clear there's a natural flow from mine into his, and Tim takes a much sort of a broader and higher level in terms of governments and organisations. This is probably a better way to start things round. Over the last decade, the concept of evidence-based policy has really grown up and matured. I'm going to talk about what we've learned over this decade. I'm also going to talk about why researchers get frustrated with policymakers. And then we're going to go look at what are the current solutions to this frustration, and to what we've learned by how the links between evidence and policy may be made better. And I'm going to talk about a research and policy exemplar that perhaps obeys some of the rules of how policy should influence evidence, but perhaps disobeys others, and that's quite interesting too. It's clear that something fairly dramatic has happened to our understanding of the link between evidence and policy in healthcare. This is the cumulative number of citations related to evidence-based policy in Medline. And before 1997, this is basically a passing interest in Medline, barely 200 or 300 citations since the 50s or 60s. And then, interestingly, after around 1997, when the Blair government came to power, there's been an incredible acceleration of citations. So, great interest. And now the link between evidence and policy is a bona fide object of scientific study in and of itself. So what have we learned? Interviews with policymakers and managers have been quite useful, certainly from the research perspective, in finding what evidence is useful for them. What are the factors that will improve a policymaker's use of evidence? And a number of different studies have converged on similar themes. Interaction with the research community, not just the odd email or how to go to a web link on a university research page, but an enduring, meaningful dialogue where both parties can interact and shape views and strategy of the other. Timeliness. Policymakers obviously sometimes need to make decisions here and now for hot, live policy topics, and finding evidence that fits in within that time frame is difficult. Also relevance. Policymakers have a certain regional bias, whether that's at national for global research or within a more sort of local authority area. There is local context, and that might impede transferability of knowledge generated elsewhere. Clear recommendations. Policymakers say that if there's a clear recommendation in research, it's easier to use. Now, those of us who do research know that part of that research process doesn't always generate a clear, unequivocal answer. We're perhaps better at being able to describe the uncertainty rather than necessarily saying there are clear, unequivocal answers. Fit with current policy. Does evidence gel with what else is going on in the wider political context? And we'll talk a little bit about that in a moment. And also a positive policymaker attitude towards research and the research process. These things, perhaps unsurprisingly, have improved or have been said to improve policymakers' use of evidence. But it's also the type of question that gets answered by a research project. If research answers the type of question, what do we know about this condition? What do we know about this particular part of the population in the healthcare? Those questions, when they're answered, that kind of research is more used. Also, what works? But not just what works, it's, well, what's the benefit? What's the harm? And what's the cost? Those three axes that researchers may not necessarily consider all at once in one report or in one framing of a research program. Research about how, if something works, how does it fit into what else is being delivered in the healthcare system? And also, we know what works, and we know that we can fit it in. How do we bring about change? Research directs against change. So what do policymakers use evidence for? This study in New South Wales asked policymakers whether they used evidence to set a policy agenda, to provide content and direction for a policy, or for evaluation of a policy once it's been implemented. And the green bars are those who used it for more than a half of their policies, and blue bars are for those who use research for less than a quarter. Okay, you could quibble with the way they've carved it up, but basically it shows that, certainly within the Australian context, research is much more likely to be used once and the policy agenda has been set, so for direction, steer for policies, rather than necessarily for evaluating them or for setting them. How can we use evidence more? Well, simply saying use more evidence isn't the answer. This is a report from Andy Oxman's interviews with World Health Organization directors, but who recommended that evidence be used in their guidelines for their recommendations. And so Andy Oxman set about testing this. Do WHO directors abide by WHO recommendations to use evidence? And it turns out that he's made out that they don't do that much, but actually, and there was a pretty fierce letters exchange afterwards in the Lancet, but the directors themselves realised that there was a need to use more evidence, even though there were guidelines. Okay. So simply saying just use more, have a guideline isn't enough. So what are the barriers? Again, this is mainly data coming from discussions with policymakers and managers. Accessibility, being able to get hold of research in a timely way from a reliable source, and then appraisal skills afterwards once you get hold of it. Barriers to using knowledge generated elsewhere from research reports is impeded if local needs aren't addressed, and that's part of a wider problem of relevance and perceived relevancy. Also, mistrust is interesting, and that was related to what some policymakers were saying was about the political naivety in some researchers who see research as a discrete event, policy as a discrete event rather, and rather than researchers appreciating that policy is an evolving, continuous process rather than one thing that they can influence at one point in time. And unsurprisingly, given that the presence of a meaningful relationship is a facilitator, the absence of a persisting meaningful relationship is a barrier. Why are researchers frustrated? This example is interesting. It's around the exercise referral scheme. This is where patients being seen by GPs in primary care, GPs were able to refer them to have basically a well-being prescription, so they could prescribe exercise. We'll pick the story up in 2000. The Department of Health wanted to expand the pre-existing exercise referral scheme as part of a program to target health inequalities, among other things. 2001, a national quality assurance framework issued by the Department of Health to improve the quality of the exercise referral schemes. 2005, a health development agency review said, well, exercise referral schemes are very prevalent. Up to 90% of primary care organisations have them, but they're under-evaluated. Nevertheless, a DH white paper, Choosing Health, said, well, we need to expand exercise referral schemes, and the Physical Activity Action Plan as well endorsed their use. 2006, a nice rapid review. There's short-term benefit from an exercise referral scheme, but there's no long-term benefit at 3 months. And there's insufficient evidence to say whether or not the referral schemes actually reduce health inequalities. Nice guidance said, well, there's insufficient evidence for exercise referral schemes after the rapid review, and if they are being implemented, it should be part of a research study. And so their implementation advice around the guidance was actually around how do you withdraw funding from an exercise referral scheme? What are the risks? And this is interesting because there are obviously non-clinical benefits of a health policy. Certainly for exercise referral schemes, health and social care and local authorities were working together, and that partnership is a good thing in and of itself, outside of clinical benefits to individual patients. So they said, well, when you're withdrawing funding, be mindful of those partnerships because those are a good thing in and of themselves. Nevertheless, in Our Health, Our Care, Our Say, from the Department of Health, the exercise referral scheme pilots are successful. And a press release about the exercise referral pilots said, well, in those that completed them, 70% achieved or exceeded their activity goals. Sounds good. But in the evaluation report of them, there's only a 10% completion rate. So a tenth of the people who went through those schemes had a 70% a target achieved of our activity goal. And the HTA, the Health Technology Assessment, funded a randomised controlled trial. This was comparing advice versus being referred to a leisure centre or to a health instructor. Advice only was as effective as the exercise referral scheme. And it was more cost effective. Unsurprisingly, you got the same benefit, but it cost less. But the DH response, we should continue to provide exercise referral schemes for selected groups. And they said, well, if there's no underlying medical risk or no underlying condition, then that should be in part of a study. The implication being that if there is some kind of risk, the evidence has already been established. But in fact, this RCT recruited people who had medical risk and found no benefit. So there's a perceived disconnect here between a policy that's progressing, and it's progressing in parallel as an evidence base is being more sort of securely identified, but there doesn't seem to be much link between the two. And in fact, Soden and Rain, who published that study on the evolution of evidence about external referral schemes, said, well, maybe the option would be, if a policy is intended to be rolled out, have it in a stepwise way. And Brown and Milford illustrated this really nicely. So imagine you want to implement an intervention, and that's this thing in blue, and you start off and you'll say, for example, 5 areas here at this time where no one has it, and then you gradually, stepwise, you roll it out. At least it gives you a chance to get some comparator data. Okay, it's not in a randomised trial, but at least it gives you a chance to get evaluation as you go, to give things a bit of a steer. How do we tackle these barriers between policymakers and researchers? In the UK, there are a number of institutions that do this. The National Institute for Health and Clinical Excellence provides guidance that's relevant to commissioners, policymakers, practitioners alike, with a strong focus on economic justification for interventions. One branch of the National Institute for Health Research is the government-funded major research programme for the NHS for better health. It has something called the Service and Delivery Organisation. It's around healthcare organisation, and its specific setup was to improve the evidence base for healthcare services and healthcare organisation, with a specific steer that should put evidence into practice and policy. And more recently, a public health research programme has recently been set up. So we're going to focus a bit about the SDO and say, well, what happens when you provide a forum to ask policymakers how they want to use evidence and what kind of research questions they have. Over the last 10 years, they funded well over 250 different projects. These are all detailed on their website. And it's quite interesting if you look at the kind of research methodologies that are needed to answer the questions that are being brought to them. They have listening exercises with policymakers and with CEOs of trusts. So the questions that come to them about burning issues for healthcare organisation delivery, what do we need to answer them? And a lot of these questions are, what do we know about kind of questions. A lot of literature reviews, mixed method reviews, scoping, service observations. These are methodologies that are most often needed to answer their questions. Randomised controlled trials and cohort studies, and to an extent, sort of some of the service evaluations, constitute quite a small number of the overall piece of commissioned research from the SDO. So questions about what works aren't at the moment asked as much as questions about what do we know about. 3 days ago, it was World Stroke Day. Post-it reminder that across developed and developing economies, there's a 1 in 6 lifetime risk of stroke, and coordinated prevention and treatment strategies are needed. The response to the challenge posed by cerebrovascular disease was enshrined in this document for England and Wales anyway, the National Stroke Strategy. Chapter 2, Time is Brain. I'm going to talk about a research programme that was very influential in setting out this strategy for certainly delivery and organisation of care for patients who've had something called a TIA, transient ischemic attack. For those non-clinicians in the room, this is where patients have a sudden focal deficit either of movement or speech or vision or sensation, and that usually resolves quite quickly. So the patient's back to normal, as it were, afterwards. But they are at a very high risk of a recurrent disabling or fatal stroke after that. So it's a healthcare emergency, and the healthcare system needs to be able to respond to a patient with a TIA as part of a coordinated stroke prevention strategy. The VASCAN Study, it's a prospective population-based study. It ascertains all cases of TIA, minor and major stroke, as well as ischemic heart disease and peripheral vascular disease for patients who are registered at 9 general practices. So it's a population base of around 90,000. It started in 2002 and recruitment's ongoing. So there's complete ascertainment of cases and 99% follow-up. So it is a population-based study. And this has come up with some extremely important messages for how stroke care should be organised. In this paper, Peter Rothwell, who is running the study, and colleagues, showed us that actually the risk of stroke after TIA is extremely high in the first few days. Previously, patients would be referred to a stroke or TIA clinic, and some just wouldn't turn up, and it was left at that, they didn't turn up. In fact, they're on the ward having had a major stroke. And these insights were facilitated by this population-based study. And this shows the risk of stroke in the days after TIA. So for TIA and for minor stroke, these are for people who have a persisting deficit beyond 1 day, but it's quite mild. And their risk of having a recurrent stroke is very high in that first week. The risk still goes up, but not by as much. So the first 7 days, certainly the first 24 to 48 hours, it's a high-risk period, a high-risk window. So they're high-risk patients. Can we identify them? Well, using data from this study, a simple risk score was developed that will be able to define who these high-risk patients were. It's called the ABCD score. And in this paper, they tested the score to see how well it would sort out the high risk from the low risk. And this particular graph is called an ROC curve, but basically it tells you how well your score is at sorting out high risk from low risk. If these lines were along there, it'd be the same as tossing a coin. You can't tell between high and low risk. The nearer you are to this line, the better you are at being able to say who is high risk, and the nearer you are to this bit up here, the better you are at picking up the high risk. So certainly it performs really well. So it's a good score for being able to pick up high risk. But not only that. Halfway through this study, the prescription pattern was changed in the clinic. Now normally, for patients who get referred after TIA, or for most things, you get seen in clinic, the consultant dictates a letter. That then gets typed up. It then gets posted in an envelope. It then gets sent in the post to the practice. It then gets opened and put in the GP's tray. The GP then reads it. Now what they did was say to the people coming in clinic, here's your medicine. So they cut down the median time for getting your medicine from 20 days to the same day. What happened? So this is a sequential population-based comparison. Nothing's being randomized. We're doing everything in a population, and then we're changing what we do in the population after a certain time point. So you see this very high risk of stroke after TIA here. This is in the first phase with the 20 days. You then do it in the same day. This is the risk. A very impressive absolute risk reduction of about 10%. And this study was very influential. But does that use of evidence fit with the evidence around evidence-based policy? One editorial a few years ago said, relying on the most recent or well-known study carries several risks, including the following: low statistical power, researcher expert bias, contextual variability, and policy relevance. But thinking back to what policymakers found useful, well, the whole OxVasc program answered questions around what do we know about? Well, we now know that actually there is this very high risk after TIA, and we know we can predict that risk. What works? Well, we just changed the way we prescribed. How do we fit this into the system? Well, we just changed. How do we change? We just did it because it was simple. So intuitively, this whole research program was very, very appealing to policymakers. Understand we had a very strong influence on the stroke strategy. Why does strategic fit? Part of the Blair government's mandate was to reduce health inequalities. This is where your income determines your health. And in London, on the doorstep of policy making, this is data from the London Health Observatory. The more purple an area is, the more deprived it is, using a certain scale. And the more blue something is, the higher their age-standardised mortality from stroke is. And there's a reasonable fit between areas that are very deprived and areas that have a higher stroke mortality. So stroke is an example of a health inequality. Okay. So understandably, a desire to use evidence that fits that wider context is important. Not only that, my interest as a GP was in what contribution does primary care make to stroke prevention. And at that time, there was a policy about increasing primary care opening hours. And I heard a number of my colleagues in meetings say, well, there's no evidence that increasing opening hours does anything. Well, that's a research question. If you look at the study and you look at how long people take to call for help, and look at the time of day that their TIA happened, how long do they take to call for help to arrange an appointment with their GP? 3/4 of patients in this study went through primary care rather than go to any. Other countries I know it's almost the reverse. Holland and North America. But in England, certainly most people go through general practice. The time of your event pretty much determines when you're going to call. Why? Because people wait for the earliest opportunity until their GP opens. So these are patients who have their TIAs out of hours on a Monday to Friday. So if you have it at 7 in the evening, that's how long you wait, i.e. your GP opens. The nearer your time of your TA is to the nearer that your GP opens, the less you wait. If the patient's on a Sunday, again Sunday morning, you wait this distance. Sunday evening, you wait this distance. And these circles are people on a Saturday. So it's pretty clear that opening hours do influence when people call for help. And that's actually going to have a clinical impact because we know of the high early risk of TIA. But interestingly, before this was published in the BMJ, the peer review picked up something in their argument. In order for argument to say this is an important issue, they have to accept that urgent treatment reduces stroke from this sequential population-based study, not a randomized controlled trial. And one stroke physician said, well, acute intervention has not yet been proven. It is observational and therefore, to an extent, uncertain. And this was peer review in BMJ. But it's good enough for government policy, not good enough for this chap from the BMJ, which is interesting. And then we're thinking, well, if this had been pitched as an individual research project, we would like to ascertain whether or not we can reduce recurrent rate of stroke by changing a prescription policy in clinic. Would it have been funded? If this sort of peer review would say, well, you need an RCT to show that rather than a sequential population-based comparison. However, if I thought that peer review was harsh, it was nothing compared with the peer review I got from the clinical community after the paper was published. Dr. Lasserson, why don't you find something useful to investigate or retire? I bet Dr. Lasserson doesn't get off his, you can get those in the evenings. Who was this idiot Lasserson? Oh, this one's infuriating because that should be a capital L, as it's my surname. We know about the needs of policymakers, and we know which methodology is currently needed to answer their questions. And we can see the frustration felt if policy can appear to be disconnected. But I think interestingly, some of the most influential research, I'm talking about the whole Oxford Vascular Study, happens outside this formal evidence policy linkage. And for me, that's quite an interesting thing. We can set these links up, but actually there's something about timeless and wider strategic fit that might determine much more how much of our research, from my perspective, gets into evidence. Infuriatingly, Muir nicked my two quotes I was going to finish on. I couldn't believe it. But anyway, this was by John Maynard Keynes, but I'll say it again. And this quote, I think, challenges policymakers, and this one challenges me as a researcher. Nothing a government hates more than be well-informed. Makes the process of arriving at decisions more complicated and difficult. And Muir said, in the end, values will always be more influential than evidence. So there's certainly a strong steer for both policymakers and researchers around a trade-off between values and evidence, and hopefully we truthfulise somewhere in between. Thanks very much.
Thank you very much, Dan. I should have said this at the start. Both Dan and Tim will take questions. Our second speaker is Dr. Tim Wilson. He has a wealth of experience in a wide range of areas. He's currently partner at PricewaterhouseCoopers Healthcare. He's been involved in the Department of Health Strategy Unit, and he's also practiced as a GP. And Tim's talk today has got the intriguing title, Policy and Evidence, What Matters is What Works. So I'm keen to hear what he has to say about that. Thank you.
And again, you can hear me, that's all right. And if you can't hear me, we can turn it down, or whatever, or if you can hear me, whichever. Anyway, actually, I sort of changed the title slightly, but it is, in effect, much the same. And the reason Dan and I thought we'd just run through is actually there is quite a complementarity between our two talks. And as Dan said, if you like, he's now outlined some very interesting specific interventions, albeit very complex interventions, whether it's exercise referral scheme, opening times of GPs and effect on stroke. And I'm sort of perhaps moving us up to a much bigger, more macro level. How does health policy work? And this is really based on a lot of experience and a lot of thinking I've done over the last few years. I was fortunate enough to be a Harkness Fellow, and the subject of my Harkness Fellowship was to go and look at collaboratives, or the Breakthrough series. And collaboratives, for those of you who don't know, were a very fashionable sort of form of quality improvement around the early 2000s. And everybody wanted to know, do collaboratives work or don't they? Well, my answer to that question, I can tell you categorically, is somewhat. And this is probably going to be the problem with all these things, is the answer to all these questions is somewhat. So I'm going to ask you 3 questions. I'm going to pounce on 3 of you in a minute, because I'm going to ask you to be the Secretary of State for Health in England. I'm then going to talk a bit about causality and effect, picking up a lot of what Dan was saying. Then refer to sort of some about the political and media context that policy decisions get made. And when I was working at the Department of Health in the strategy unit, this was the aha moment for me, the difficulty around that. And then the final bit, I suddenly realised actually this also reaches into work I've done in the past around complexity and judgment. So I'm going to just pounce on you. So you're number 1, you're going to answer the first question, okay? You're number 2 and you're number 3 because you're looking away. All right, so just putting you on the spot now, GP commissioning, big policy, do you do it or do you not? Yes, okay. Referral management, or just referral management schemes, do you do them or not?
Somewhat.
So, no. You've got to do it. You're the Secretary of State. You can't somewhat do something. You're going to do them, okay? And life-saving cancer drugs to children, do you do them or not?
Yes.
Okay, thank you very much. So actually, yes to all of those. You're a very positive bunch, I'm glad to say. So you can't answer somewhat, because that's the key to all this. This very complex diagram, it comes from a piece of work we're presently doing around health inequalities, where we're helping local authorities and PCTs try to think through the linkages between the things they do and what the final impact would be. So they're trying to reduce overall at the top there the inequality gradient in childhood obesity. That's what they're trying to achieve. And what they're doing is, in a certain context within the organisation, they're putting on all these different sort of bits and pieces. This is a fairly incomplete set of things, but it just gives you a flavour of the complexity of the interrelationships. So an education programme could affect motivation, which might change local pride, which might have reduced crime rates, which may mean more children are willing to walk to school, increased level of activity. Do you see what I mean? So these things, doing something here will have an effect there, which have an effect there, which might have an impact there, and so on and so forth. And that's what I want you to bear in mind. Interventions aren't simple. There's not a direct linear effect. There was a fantastic paper, or a couple of papers actually, by Richard Lilford and colleagues, who started to sort of say, well, okay, how can we think around this? So this paper, I think, well, it's got the date here, so it came out earlier on this year. Very good paper, started to think about what is it that works. And so they were saying, look, if you put in some sort of intervention, it could be down there, X, and in this case that could be exercise referral scheme, or it could be getting people to a stroke clinic or getting people stroke care quickly. There's a whole range of other things that need to go on, the structure of the service, the policy interventions, intervening variables, and so on and so forth. I think this is a very brave attempt to start to understand the context in which all these things happen. I have to say, as you will gather from my previous diagram, I think it's probably somewhat oversimplified, but hey, it's a good start. Now, whenever you're putting a policy in place, you're trying to get, a movement, aren't you, in the curve? So we'd normally have a sort of, usual distribution curve like that, for whatever. So for our colleague here, who's somewhat going to do referral management centres, and you might want to increase referrals or decrease referrals, whatever it might be. You want to see a move, don't you, in the shift in the curve? So it has an effect overall. I think that's probably right. The problem is it doesn't work like that. The net cause of my causality diagram, or Richard Lilford's work, is there's all these feedback loops. So you don't exactly go from here to here. There's all these other intervening factors in place. What are the incentive structures? What are the other policy things? What are the things that what effect does the national tariff or payment mechanisms have? What does the actual organisational structure have? What does professional development do to all this? You can start to imagine all the little factors that go into here that are going to influence this outcome. And what this made me realise, and this is why at the end I come back to complexity theory, is there is a thinking around complexity theory that when you take four distinct bodies, planets, let's say, it gets to the point where it's impossible to actually work out gravitational effect because the feedback loops are so complex. And the problem, what I'm sort of starting to say here, is because you've got this sort of feedback loop that's getting so complex, and minor adjustments might have huge effects over here, you're starting to think about complexity theory. This gets really difficult. So world-class commissioning, we've got a mixed audience here. Some people in the audience will know what world-class commissioning is, some won't. World-class commissioning was a big program run by the Department of Health to improve the quality of commissioning or purchasing of healthcare in England, and it was basically an assurance program where people went out to visit PCTs and rated them. As a bit of naughtiness, we looked at the relationship as a firm between their score on a particular competency, number 11, and that competency is about value for money, and the degree to which they're delivering value for money. And this is the savings by population per 100,000. Now this comes from nationally available databases about what savings could be achieved. When I say savings, it's things like avoidable admissions or moving to cheaper statins or whatever it might be. A range of different things go into this pot here. And I think you can pretty much agree there's very little correlation between this, what you might say, savings here and their score. So higher scores did not necessarily translate to more effective or more efficient. And we've got other graphs to show you a similar sort of thing. So let's move on. Let's think about GP commissioning. So answer your question, do GP commissioning, yes or no? And our Secretary of State said yes. And you're absolutely right. It is yes. Possibly. Because it all depends what you're trying to achieve politically. So Muir's point about values having a greater driver is absolutely spot on. When political parties come in, they come in with a set of ideologies and beliefs, and that's what drives them. So when I was at the department, this is actually one of the things we did around what we call practice level incentives. And this goes way back 7 years ago. So you might say this is the start of the thinking around GP commissioning. And we did look at all the evidence base and the research out there, both, and try to extrapolate international stuff and said what would happen in the UK context and so on. And we tried to boil it all down for the policymakers. And this is what we realised. There's a number of things. One is you could look at the range of different types of budget you give to clinicians. This is what we're heading to, full real practice level, well actually it's consortia level budgets. I suppose maybe it's that one actually. Real practice level, so you're moving right up there, but it's real budgets. But with that movement, moving up this scale, all these things happen. Now look, some of these are interesting. We said alienating the profession is more likely to happen the more real budgets are. Because we know the history of GP fund holding, incredibly well researched. It's probably one of the most extensively pieces of research of policy ever. And we know that the profession was incredibly divided, so it was alienating. On the other hand, many of the profession was highly motivated. So you get some of these things that happen which seem apparently contradictory. The more you go up here, the more likely you are to get a motivated profession who are willing to engage, but actually you're probably going to alienate a whole load of them at the same time. Incentives and drivers for change go up here, but you might get more likely to get distortions and gaming. The higher up you go here, the harder you make those budgets. So provided our Secretary of State here is willing to accept distortions and gaming, but actually wants to increase the incentives and drivers for change, she's quite right. It all depends what you want to do. So a piece of policy will have mixed effects. In answer to our questions, so our favourite newspaper, the Daily Mail, I don't know, again, for folks not from the UK, they perhaps won't know the full glories of this newspaper, also known as the Daily Whale. Here it is, here's the headline. And I thought for this talk I had a quick look, didn't have to look very far. There's something in the paper today about children with bone cancer denied life-saving drug by NICE. NICE is the Daily Mail just thinks NICE is the devil incarnate. You look at the NICE appraisal. What does it say here? It basically, the drug doesn't make much difference whatsoever. It's phenomenally expensive and really makes zero difference. The confidence intervals look pretty much all go across one. Life-saving drug doesn't work. So, and yet, this I can promise you is what Mr. Healy, who's the Labour Party health lead in the department, is saying to Mr. Lansley, "You're denying my patients life-saving drugs." Okay? That's the context. Referral management centres. So somewhat, I mean, I think we finally got you to say that yes, you go for them, go for referral management centres. This is interesting. This is the press release up here from the King's Fund. So if you go to the King's Fund website, look at press release on their paper on a really good report on referral management centres, I hasten to add. That's failed to deliver, so I'm afraid you got it wrong. Unless you actually read the report where it says they do work, but somewhat. So your answer was right. Somewhat was a pretty good answer. And this is the context. If you're the Secretary of State and making a decision, do I roll out referrals management centres? The answer is, yeah, but only under circumstances. There's a nuance here, there's a subtlety here. Not all referral management centres work. You know, just building a referral management centre and then, you know, putting a label referral management centre isn't going to work. Doing some of these things, that works. So this is where you get to the subtleties. The whole thing about, so the aha moment for me when I was in the department was sort of thinking about who decides. And there's this very complex thing we're heading towards. It's not, this is for the new world of the NHS in England. It's no different nowadays, really. In that you've got an individual and family who receives care from the clinician, who's a member of the practice, who will be a member of the GP consortia when GP commissioning comes away, when our new Secretary of State has her way. But you see there's this link all the way around here between the individual and their family, the care they get, as what they get as electorate, they vote for Parliament, government, Treasury. And there's a fundamental disconnect here between when people vote and what they do. So this decision, whether you do something or don't do something, is never driven by that voting process. That's where governments are generated from, by the electorate, who create parliaments, who then create the government. And that's the problem. And the problem is also that these things have to be either yes or no. That's why I wouldn't allow you to say somewhat. You can either implement GP commissioning or you can't implement GP commissioning. Although you can implement referral management centres in a certain way. So that's when the subtleties come in. But you can either do them or not do them. So bearing in mind what I was just saying about the the 4 planets, when they come together, you can't work it out, and the sort of extreme complexity and the complex set of things we're dealing with. This is where I sort of realised actually this is where complexity theory might help us. So we have this sort of quandary at the moment. Kieran Walsh, a professor up at Manchester Business School, has written extensively about how terrible the present reorganisation in the NHS is, and yet it's in the full knowledge that we have no evidence that the present system actually works. Does it work? Does it not? I think somewhat. Answers everything. But there is evidence that that describes the strengths and weaknesses. So actually, is it worth fine-tuning or changing it? Yes, probably. Is it worth the tumultuous changes? I don't know. I honestly don't know. I tend to be more in favour of the current policy, but you probably guessed that from my previous research. So one of the problems we have is that we think of the NHS, and this could be true of any health system, but this is the NHS in England just for the moment, as a machine. We think about bits in isolation, we think about stroke care, we think about referral management systems, we think about exercise and referral. We think about these little things, but you can't think about them in isolation. There are many other factors that play. We often specify the changes in detail. So the exercise referral scheme is a brilliant example of where a minister wanted a policy. It was very attractive, let's get fat people exercising, that's really good, the Daily Mail's going to like it, it's going to be terrific, let's do it. And the policy was driven through, and yet, so that's often a problem. We often spend our time battling resistance to change, when actually resistance to change is more often about traditionalism. People have got a better idea. So those people who didn't do the referrals to exercise referral schemes, those Richard Lehman, another Oxfordshire GP, who spent a lot of time shouting about going down to 7% HbA1c in the Quality and Outcomes framework, he was quite right. His resistance to change was actually jolly good. His resistance to change is about saving lives, thank you very much. And this constant idea of reducing variation as well. So if we think about the NHS as a complex adaptive system, it's about a series of agents that work together, that interact, and it's not always predictable, and whatever they do, it sort of co-evolves. So GP surgery are linked with other GP surgeries who are linked with the PCT as it presently is, or consortia as it will be as, they're linked with the hospital, they're linked with, so on and so forth. And all those linkages and relationships are very complex. Their contracts have a factor, but it's not a consistent factor, so on and so forth. And that's a complex system. And the way you can recognise complex systems is that the agents in the system adapt. So whenever a policy comes in, my goodness, the NHS will adapt to it, sometimes in a positive way, sometimes in a slightly more negative way, as with the 4-hour wait, where there were all sorts of strange behaviours. Systems are embedded within systems, so that we've already talked about this idea of government and then policy and so forth, right down to organisation and individual level. There's always tensions and paradoxes. We've heard about our new Secretary of State here. If she implements GP commissioning, she'll get one positive thing, but the tension and paradoxes she'll cause other problems elsewhere. You often get an amplification. Suddenly, something, that little loop of effects I've talked about, suddenly can make something happen, really extraordinary happen, that you just didn't believe. And then often shadow systems. So this little picture here is a reminder that when you go to a meeting and people talk about things, actually that's not the interesting stuff. It's what they talk about at the water cooler that's the really interesting stuff. And so these shadow systems often exist. Let's just crack on quickly. This is just one way of thinking about it, and I'll finish with this slide. We published this paper in the BMJ way back in the beginning of 2001, and the idea is when you're thinking about putting policies in place, you can start to think about the degree of certainty you have about the evidence and the degree of agreement about what you're about to do. Okay, so some policies come with high certainty, high evidence, and those will be considered simple. Some have low, nobody can agree, and the degree of certainty is very low. That's what we might call chaos. But a lot sits in this zone. GP commissioning absolutely sits in this zone. Referral management still sits in this zone. It's bordering on there. Cancer drugs bordering on there. And the different things you do, frankly, when you've got things in the complex zone, you just can't regulate, whereas in the simple zone you do. So some of the things you should just do. So for instance, putting in a venous thromboembolism program, there's such good evidence around that, we should just frankly doing it because people are dying for not doing it. Whereas some of the other bits, GP commissioning or not, referral management system, you've got to try. So the real message I want to sort of give here is when you're a Secretary of State, there is evidence out there. We've heard a lot about that from Dan. There is other forms of evidence. You can use that, but because you're doing things within a complex environment where you're not quite certain of the outcome, and because of the environment in regard to the media and the political environment, you've got to use your judgment. So I'll stop there.
Thank you very much, both of you. You've given plenty of time to ask questions, so I'll invite any questions from you.
Yeah.
The gentleman at the front here, if you could just say who you are, Taz has got a mic and
I'm Vladimir Hachinsky from Canada. My question is a very general one, and that is, I think we have heard that all healthcare systems are unsustainable, and we have to improve quality. But one factor we haven't talked about is personal choice. In other words, the governments may pay for certain drugs because they're cost effective, but there may be things that are less cost effective, that have a high price, that individuals may be willing to pay for. What do you see the role of personal choice in sustaining the healthcare systems?
That's for you, I think.
Yeah, I think it is.
Yeah.
Do you know, I think that comes back to the ideology that any country or political party has. So for some, the notion of people being able to buy better, or what you might call more marginal cost-effective healthcare is antithetical just to the nature of the country or their political ideology. So, my personal feeling around that, well, that if the NHS or another health system is providing all that is effective, and someone wants to purchase something that is only partially effective, that bone cancer drug, then that's fine. So long as we're not, from my own opinion, so long as we're not denying people who cannot afford it effective treatment, then I'm more comfortable. The problem I have is the way, if we just use that example of the bone cancer treatment, is often the way that it's often, shall I say, sold to patients. So Sophia Christie, who's a PCT chief exec in the Midlands, she talks about this not in terms of does it work or not, or and so on. She talks about this this is more like a human rights abuse. So people often come back from the, apologies to fellow oncologists here, but she talks about people coming back from oncology clinics being told that the PCT has denied this life-saving drug. The truth is actually this drug might give them 3 or 4 months extra life. And they then go away and they try and raise the money, and they have a Just Giving page and so on and so forth, or they mortgage their house and they pay for this drug. They get 2 or 3 months of extra life at the cost of misery while they're taking the drug. So actually, I think this is not answering your question. I think there is actually a question before this: are some of the low-value treatments, should anybody be allowed them even? Even if they had the money, should they be allowed to buy them? Or under what context should they be allowed to buy them? And the answer is under the context of fully informed consent. And I don't think most people get fully informed consent for that type of drug.
No, I'll just say that I think there's a research angle there too, just about our risk communication in the consultation. There's a lot of work going on that needs to be done still on making sure that consent is fully informed, and how, as clinicians at the front line, we are best able to fully elucidate risk and benefit. And often the decisions patients make are absolutely bang on.
There's a lady in the green, just about 4th row.
Hello, my name's Penelope Jarrett. I'm a GP in London, and you're the first gentleman, your presentation, wherever you said researchers were frustrated, I'm sure you could put clinicians in there equally well. We've had all sorts of policy initiatives foisted on us with no evidence, or with the sort of spurious evidence. I was particularly frustrated reading the Healthcare for London proposals when they had the story about going down the tube line and your life expectancy decreasing as you go east, which is entirely true. And then somehow this elided into we had to have GP-led health centres, and there was no... The implication was that this was going to solve this problem of variation in life expectancy, but they didn't actually state that. And of course there was no evidence. And it's very, very difficult to argue with these sort of nebulous suggestions, and it was somehow, those of us who did argue against it, were somehow seen as not really caring about our patients. And I don't know how we try and encourage the policymakers to be evidence-based.
I guess this is part around the dialogue, isn't it, between policymakers and researchers. Could you come on the mic for a second? Can I just ask you, you said when you came back to them, what did you say? How are you constructing your bit of the dialogue in terms of saying, we don't need this?
Well, I mean, I personally did a feedback, because they asked for consultation. I don't know whether they ever listened to any of this, and I said that I couldn't see how I didn't know of any evidence, and they didn't present any evidence. Rather, to the contrary, some of the stuff they had in the appendix didn't match up with the rhetoric in the main body of the thing. And obviously, and I talked to people locally in my borough, PCT and so forth, but I think we were just ignored.
Either that, or it may not be that you ignored it. I never wanted to tip, but it's about the whole value evidence thing. And I think it's the point that actually, the health inequality, certainly for the last government, was such a major plank that in the sense they were prepared to go possibly into areas where there wasn't a secure evidence base, and maybe with the hope that they would come along. I don't know if you want to add that to.
I think that's a very good example where people leapt to the solution for the problem, where there might have been multiple solutions. So The evidence around the impact of good general practice on health inequalities is fabulous. So Barbara Starfield and others, just fantastic. So good quality general practice helps reduce health inequalities. And the second thing that is pretty much incontrovertible is the patchiness of access to general practice in more deprived areas. It has always been harder to get. There are lots of examples. There are lots of exceptions to what I'm about to say, which almost make it more frustrating, frankly. But the evidence base around access to primary care or general practice specifically is that in more deprived areas it is harder. So the problem I think that they were trying to describe is, look, there's huge health inequality. This is going to be helped by greater access or availability of good general practice. What can we do? A sensible approach, and what one might do in the new world of GP commissioning would be the GP commissioners sit down and say, inequalities helped by general practice, we haven't got enough good general practice, what can we do about it? And thinking through a range of solutions. What they leapt to is this solution called polyclinic and so forth. So I think you're right, there was this leap of here's a solution and it'll work. Well, the answer is, I hope we can all agree, more better access to general practice in deprived areas, good thing, good evidence. But I think there's lots of ways of solving that particular problem, which is not just polyclinics. In some places, polyclinics might have been the right thing. I suspect a lot of places, there's loads of other solutions around.
Okay, I think we've got room for one more question. So, somebody at the back, fight it out between the two of you.
Oh, we can take...
Three of you.
Take two. No.
I need that lunch.
Yes, Saeed Farouk, consultant psychiatrist. I was just wondering, what is the state of evidence about involving the policymakers in designing the studies which produce the evidence?
That's a good point. Study design. Canada has, I know Canadians here, but I think there's links between policy and research in Canada that I've read about that seem quite functional. In this country, certainly the Service Delivery Organisation research branch, the AHR, is a bit of that formal link. But in terms of what extent they design studies, it tends not to be that well sort of formally set out. Typically, there'll be a commissioning call from the SDOs to say, we want to know about this. And then it's up to the researchers to come back with a design that they think will help answer that question. I think there's no quite formal link, unless Tim, you're aware of.
Well, there are links. So just for instance, at the moment, they're looking for. This is actually quite encouraging. Actually, they're looking for a range of so-called Pathfinder sites for GP commissioning, and they deliberately said we want a whole range of different sites doing different things in different ways. There are a few sort of criteria, but actually we're happy to have different models because we're not quite sure of the right model. And one of the things they're doing in parallel with that is setting up a centre for commissioning research around this to look at those different sites and work it out. So there is a sort of very formal linkage that's going on there. So you do occasionally see it on particular policies, and actually the good news is on this particular policy they seem to have actually sort of thought about it and listened to some of the criticisms going on. Whether this will play out, the danger is if none of those sites succeed, what will they do? Will they behave in the same way they did around exercise referral programs and so on? Well, only time will tell. But at this point, I'm quite encouraged by that asking for diversity and actually in parallel setting up a research centre which will absolutely work alongside all those Pathfinder sites.
Okay. Thank you all very much. For those of you who weren't able to ask your question, Dan and Tim are around during the lunch break, so hopefully you can get a chance to ask it then. Thank you all for coming, and thank you to the speakers for raising more questions than they answered, which I think is the addition of a great speech. And I hope that over the water cooler that you can come up with some answers. Thank you all very much.